Well, thank you very much, and I appreciate the invitation to speak. So I think that to some degree, my job here in the lineup is to give you a little bit of the state of the field from the clinical perspective in BRCA-like phenotypes and what their potential promise might be, acknowledging that the field is really quite nascent despite already a number of years of effort, that we have a long way to go, but I think we're starting to make progress. So we're talking about the BRCA-like phenotype. This is my disclosures. So obviously the interest in BRCA1, 2 is because they are an important cause of breast cancer. BRCA1, 2 are the most common identified single genetic cause of breast and ovarian cancer in the world. A number of other genes contribute, some of them DNA repair genes functioning in common pathways with BRCA, and a number of other genetic causes that have not been identified. But really the ones that we understand the best are BRCA1 and 2 associated cancers. Just so that we're all the same page in terms of the clinical phenotype, patients who harbor germline mutations in BRCA1 have up to an 80% chance to developing breast cancer to age 70, and BRCA2 somewhat lower but comparable, and also a marked risk of ovarian cancer, 40% or more for BRCA1, up to 20% with BRCA2. And because of increased awareness of cancer genetics and genetic testing, we're doing a better job, at least nationwide, at identifying who these patients are, and you may be aware that there's a lot of talk in the clinical community about how we can even do better to identify these genetic carriers. So the question arises, are these tumors distinct such that we could identify genetic carriers and the particular BRCA phenotype we're going to talk about simply based on the clinical parameters that we think about in terms of, in this case, breast cancer? And it is true that for BRCA1 germline carriers, about 80% of the tumors do have a common clinical phenotype, and that, of course, is triple-negative breast cancer. These tumors are ER/PR, HER2 negative, poorly differentiated, high grade, and they express certain basal cytokeratins which have caused them to be termed basal cancers, even though I will show you they're not derived from basal epithelia. This is exemplified quite clearly in this global gene expression analysis with these intrinsic patterns of gene expression, where you can see that triple-negative cancers, which are more common in BRCA carriers, do express a series of basal epithelial and proliferation genes. However, we have to acknowledge that the majority of patients who develop triple-negative breast cancer do not have germline BRCA mutations. Furthermore, when we talk about BRCA2, there are some common clinical phenotypes. Most BRCA2-associated tumors are ER-positive, also high-grade and aneuploid, but unlike BRCA1-associated cancers in that respect. So why might this be, and does that help us in terms of how we can identify these tumors and their phenotype? It turns out that probably these differences between BRCA1 and BRCA2 associated cancer relate to a distinct cell of origin and a distinct pathogenesis of those tumors. So even though, as I said, these are often called basal-like cancers in BRCA1 carriers, it turns out that they are derived probably from a luminal progenitor cell. This is the tree of differentiation of the mammary epithelium. They're actually not derived from basal or myoepithelial cells, but from a luminal progenitor. And BRCA2, probably a distinct cell of origin, which is somewhere along the lineage between a progenitor and a differentiated epithelial cell. All that to say that the clinical phenotype is distinct between BRCA1 and 2, and that the majority of tumors that have that particular clinical phenotype are not tumors that among patients who have germline mutations. So why are we interested in BRCA? Of course, it's because we have some understanding of the particular DNA repair pathway that is regulated by the BRCA1 and 2 tumor suppressor genes, and you'll be hearing more about this in the next two talks. For the purposes of this talk, suffice it to say that we have some understanding of the particular phenotype of BRCA in terms of DNA repair, because both BRCA1 and 2 are quite important for repair through a mechanism that involves homology-directed repair or homologous recombination. And this evolves as a result of a series of protein complexes assembling actually on the damaged DNA to lead to the process of homology-directed repair. And this particular clinical phenotype has given a rise to a therapeutic vulnerability. And that is because tumors which lack HR-directed repair are more dependent on other repair pathways following DNA damage, or indeed things like replication stress, which are essentially intrinsic in the absence of external DNA damage. And of course, that backup pathway that I'm talking about is dependent on the enzyme PARP, poly-ADP-ribose polymerase. In a very simplified schematic, normal cells have both pathways intact. In BRCA germline mutation-associated cells, homology-directed repair is defected, and therefore those cells are more dependent on the PARP-associated pathway, involve base excision and other steps toward DNA repair. And the observation simply is that if you take a cell in the absence of other DNA damage that has lost BRCA1/2 function and inhibit the PARP enzyme, that can actually kill the cell as a result of unrepaired DNA damage. So the question is, all right, if you can identify BRCA mutants, you can treat them with PARP inhibitors, yes, but what about the larger proportion that lack BRCA mutations? And one thought about this that has been tested clinically is, well, if PARP is an inhibitor of repair, if we simply increase the amount of damage in the cell, perhaps there will be some kind of synergistic or important therapeutic benefit of combinations of DNA damage, whether it's radiation, chemotherapy, and PARP inhibitors, perhaps even regardless of this HR defect that we see in BRCA cells. And the truth is that many of the clinical trials, which I'm not going to present today, that test combinations of PARP inhibitors and DNA damage, particularly chemotherapy, in unselected patients, have really shown that the therapeutic index is not there, that these are toxic, that the toxicity appears through largely hematologic toxicity, and that therefore these sorts of combinations of PARP and DNA damage in unselected patients is probably not going to be the major therapeutic strategy for these particular inhibitors. Therefore, the focus in using selective inhibitors like this has been on identifying instead those tumors which might have this type of homologous recombination defect in the absence of a germline BRCA mutation. This is some of the data that has been generated with PARP inhibitors. You may know now that this particular PARP inhibitor, olaparib, is now approved by the FDA for advanced ovarian carcinoma. This is actually phase 2 data in breast cancer, where patients all of whom had germline BRCA1 or 2 mutations were treated with olaparib at 2 doses. And you can see that there was a substantial response rate, here shown in the waterfall plot, whereas of course the line going down is response, up would be growth of the tumor. A 41% overall response rate in these breast cancer patients. Particularly notable was that these were highly pretreated patients with a median of 3 prior lines of chemotherapy. And the toxicity of this single-agent PARP inhibitor, particularly in terms of grade 3 toxicity, was quite low. So validating the concept of PARP inhibitors, and we all believe that these will soon be approved for breast cancer the way that they are now approved for ovary cancer and in new settings to come in the setting of BRCA mutation. But of course, the central question that we're addressing in this talk is, do some tumors which lack the BRCA germline mutations exhibit this BRCA pathway defect? Of course, the answer is yes. The ones that are easy to identify are those which have not germline but somatic mutations in BRCA1 and 2. And the data there are pretty clear that that phenomenon is relatively common in ovarian cancer, up to 10% or more, but really quite rare in primary breast cancers, that is, somatic mutations. Similarly, there are other mechanisms whereby BRCA1 or 2 themselves might be inactivated in the tumor that have been studied. 2 of the most frequently studied have been methylation, particularly of the BRCA1 promoter, and secondly, specific microRNAs, endogenous microRNAs that might be upregulated to suppress the expression, again, particularly of BRCA1. And it is clear that in a subset of tumors, there is this type of suppression. Data produced to date have suggested that that type of suppression might not correlate nearly as well with responses to specific agents as does the germline status. So the jury is really out about how much those particular mechanisms of silencing of BRCA1 and 2 themselves are going to be clinically in identifying this subset. And then we also know that among these tumors, as I alluded to earlier, that there are those who arise because of other germline mutations other than BRCA1 and 2 that function in a common repair pathway. And this might be an important way to identify a subset of these tumors, but it turns out that those tumors, those with other germline mutations, are relatively rare. So therefore, the clinical evidence suggests that really we have a long way to go and that most tumors with a BRCA pathway defect are really not readily identifiable by the strategies that are listed in this slide. So here is some of the data about this question about, well, maybe these other germline mutations and related pathways are really going to be the answer to identifying these BRCA-like tumors. And I think this was a very informative study performed by Fergus Couch and colleagues. And he showed that if you look at unselected triple-negative breast cancers, these patients, in almost 15% of the case, did harbor germline mutations which appear to be likely associated with the pathogenesis of those cancers, but that the vast majority were indeed BRCA1 and 2 mutations, more than 11%, and that a small percent, 3% or so, were associated in terms of pathogenesis with related genes in the pathway, the RAD genes, PALB2, and others. But even if you add these up, we're only talking about a very small percent of tumors which would have putatively a BRCA pathway defect as a result of a related germline mutation. So clearly, that's not going to be the answer for the majority of tumors that we think might have this BRCA-like phenotype. So then the question comes up, well, over the years, we've done a lot of work about subsetting breast cancers. In particular, let's focus for a moment on triple-negative breast cancer. This is the one, if you have a BRCA germline mutation, you have an 80% chance if you get a breast cancer that it's triple-negative. But most triple negatives are not BRCA1, 2 germline mutants. So the question is, do any of the subsets of triple negative cancer, which we have identified over the year, point to which ones are the BRCA-like? So let's go through that in the next couple of slides. So intrinsic gene expression profiling has divided triple negative breast cancers in a variety of ways. One is this intrinsic subtype which has been transformed in a clinical assay called PAM50, the larger proportion of which for triple negative are the so-called BRCA-like, with this BRCA-like expression. There are also lumen-like tumors and HER2-like tumors among triple negative. A second gene expression classifier of triple negative that divides them up was developed by the Vanderbilt group, in which they identified 7 different subsets of triple-negative tumors, and there's some overlap between these two classification systems. But these are thought to be biologically important, in some cases having emerging clinical actionability. And so the question is, could these correlate with a BRCA phenotype? Let's set that aside for 1 minute and look at another important classifier for BRCA tumors, and that is a genomic classifier based on the number of mutations, this is somatic mutations, or the types of somatic mutations in those tumors. So this is data from the TCGA where each column is a tumor, and the y-axis has the total number of somatic mutations. The various symbols show the key driver somatic mutations, be they oncogenes or tumor suppressors in these tumors, and the red are the BRCA-like classified by gene expression classifier among triple-negative breast cancer. So the first thing you can say about these classifiers is that this gene expression classifier, the red, really does not identify the tumors, for example, here with very high mutations, nor does it identify a subset with particular somatic mutations, although the BRCA-likes do have a slightly higher frequency of P53. So those are kind of a mix. But of course, the real question we're asking here today is, does this correlate with the BRCA phenotype? So we conducted a clinical trial in metastatic triple-negative breast cancer and looked at essentially all these classifiers and asked whether it correlated with the BRCA status, and that's summarized on this slide. So here, again, each column is a patient We have the BRCA germline status here, BRCA1, BRCA2, the P53 mutation, PIK3CA, key driver mutation, P6373, another marker of DNA response, and then this basal classifier where the dots are the basal, and then the Vanderbilt subtypes in the different colors here. Bottom line being that in this cohort, this is about 55 of the 82 patients that are available for analysis, and there were 1, 2, 3, 4, 5, 6 mutant patients, 7 about what you would expect in this cohort according to the data I showed you earlier, but really no correlation with any of these established triple-negative breast cancer classifiers. So some were basal, some were not basal, some were P53 mutant, some were P53 wild type, same with PIK3CA. Vanderbilt subtypes really didn't classify. So the one thing that we can say is that all these years of interesting biological subsetting of triple-negative breast cancer does not lead us to the ones that are BRCA-like. So now we have to tell you a little bit about cisplatin in breast cancer, because it turns out that there is an emerging correlation between response to cisplatin and BRCA germline mutations, and extending from those data have been a number of clinical trials which tested the hypothesis that we could predict responses to cisplatin based on a putative BRCA-like signature. So cisplatin, as some of you know who might have been practicing oncology in the 70s and 80s, was fairly popular and even used for breast cancer in that era when the taxanes came along because of efficacy and toxicity issues. Really, platinum went completely by the wayside for the treatment of breast cancer, and only has been resuscitated in recent years because of this correlation with triple-negative response, and particularly with BRCA pathway and response. And I'm going to show you some of those data in the next few slides. So it was known for many years that patients with BRCA-associated ovarian cancer, and you know that those cancers are treated with platinum-based regimens essentially universally, that BRCA-associated ovarian cancers was associated with higher response rates and better survival than non-BRCA-associated ovarian cancers. In the setting of breast cancer, one of the most informative early trials was conducted by the group here at the Harvard Cancer Center, led by Judy Garber. And this was a preoperative trial for triple-negative breast cancer, where we could assess specifically the response to single-agent cisplatin. In this case, of course, the patients got standard therapy after the cisplatin, but it was informative because we could look at the biologic parameters and correlate specifically with the response to platinum as a single agent. And so this is a very small trial, pilot trial. 28 patients were enrolled, and it turned out that in terms of pathologic complete response, which of course is disappearance of all tumor from the breast at the time of surgery, as you probably know, highly correlated with long-term disease-free survival in triple-negative breast cancer, there were 6 pathological complete responses, and at least half of those patients were BRCA mutation carriers. And I will note that those were the only BRCA carriers in the study. I say at least because when the study was actually reported, if you read the JCO paper, there's only 2, but that was in an era in sequencing when we weren't comprehensively analyzing the gene, and now it's up to at least 3, and no other carriers in the study have been identified. So clearly it appears there's some enrichment for dramatic responses to platinum in the setting of a BRCA germline mutation. So the idea about whether this BRCA phenotype was particularly associated with platinum, and secondly, whether platinum was particularly effective in triple-negative breast cancer, has recently been tested in the metastatic setting in a trial known as TNT, triple-negative trial, of which Andrew Tutt was the PI. And the idea of this trial was to simply randomize patients to treatment with taxane-based chemotherapy or platinum-based chemotherapy, look at overall response, progression-free survival, and then the association of BRCA germline mutations with that response. And these are the data. If you look at overall response, the agents look fairly equivalent. So overall response rates were quite similar, as were progression-free and overall survival with either treatment. But of course, the big difference was in the setting of BRCA germline mutations. So if you look first at the taxane responses, whether you had a BRCA mutation or not, your response to taxanes was essentially the same, but highly statistically significant difference in response if you carried a germline BRCA mutation. Again, suggesting specific sensitivity of BRCA tumors and specifically to platinum agents. So then the question became, how can one identify patients who don't have the mutations but who indeed have a BRCA-like phenotype? And many different approaches have been tried over the years. To date, probably what we would consider the most simple approach has been the one that's come the farthest, and that is simply asking a purely empiric question. If you hypothesize that the BRCA tumors have a particular type of repair defect, you might therefore posit that they would have a distinct pattern of genome aberration compared to tumors with other types of repair defect. And therefore, if you just did a global genomic analysis of what the scrambled genome looked like in the setting of a BRCA mutation or BRCA-like versus a sporadic or non-BRCA associated, you might see differences. And so that was done. In one iteration, basically a CGH, an array-based classifier, was used to look at types and lengths of deletions that occurred in BRCA mutant tumors that are known to be associated with germline mutations versus those not, looking at the enriched signal in the BRCA mutants, and then that was tested in terms of clinical response. So one of the earliest tests of that type of hypothesis was done by the Netherlands group, in which they retrospectively looked at a trial for patients with high-risk breast cancer treated with either a standard adjuvant therapy cocktail or platinum-based, in this case, high-dose chemotherapy. So there's a difference in both the dose and in the agent, but notably, this was a platinum-based regimen. And if you look at the ones who lacked this BRCA-like CGH profile, there was little and no statistical difference between recurrence-free survival or overall survival in this setting. But then if you looked at the set that had the BRCA-like phenotype, they seemed to actually do worse with standard therapy and markedly better, such that among that subset, there was indeed a statistically significant difference in both recurrence-free and overall survival with the platinum-based therapy than as there was with the standard therapy, and again, in the absence of a germline mutation. So subsequent to this work, a number of different but related types of assays have been developed, and I'm going to tell you about those and then tell you some of the clinical trials where they have been integrated. So one of the assays, it's all based on the same principle of a clinical phenotype, a genomic correlate linked to that. One called NTAI for a number of telomeres with allelic imbalance, looked at telomere allelic imbalance, and this was not a BRCA correlation, unlike the others I'm going to be telling you about, but actually was a correlation with platinum response, thinking that would be a surrogate for a BRCA-like phenotype. Another assay that has been developed is called the LST assay, again empirically derived by comparing BRCA deficient basal-like breast cancers to other basal-like breast cancers that didn't have BRCA mutations, and this had to do with different frequency of translocations and rearrangements. And then finally, the LOH assay, which looked at the size of deletions on BRCA versus non-BRCA tumors, with the observation that if you looked for a particular size of a deletion, not too big, not too small, that was associated with a BRCA germline mutation, and again, might be a hallmark of a BRCA-like phenotype. So these are the assays that have been published and have been looked at from the point of view of correlation with response. So the first question you might ask is, well, what do these assays look like in terms of the overall profile in cancers? And that is shown here in a recent biomarker paper. And what you see, these are the three assays, the telomere assay, the state transition assay, and the LOH assay. What you see is that they seem to be roughly correlated with one another in terms of the different cancers and the frequency within the different cancers. It's basically a numeric score, higher score meaning higher proximity to the BRCA-like phenotype. So higher scores in tumors which are known to have higher mutations overall, lung cancers, squamous cancers, head and neck cancers. But interestingly, ovarian cancer, again known to be enriched for the BRCA-like phenotype for the reasons that I've told you, actually came out in the highest in both the LST and the NTAI, and also high in the LOH. But of course, the real question is correlation with response. And this was tested for the LOH assay, the third assay, in the precog, that should be 0105 trial. This was another preoperative breast cancer trial looking at response in the breast. This was a combination which you could give another talk about this combination, but we'll skip that and just say that it's a platinum-based combination that was tried in the neoadjuvant setting. And again, you see that if you look at the known BRCA mutants, they had a higher response rate, again looking at pathologic complete response, than the ones known not to be BRCA mutant, and that triple negative enriched for responses as well. And then when we look at this LOH assay, what do we find? Well, indeed, BRCA mutants who responded, so this is a graph where the score, again, the high score, more BRCA-like on the right, less BRCA-like on the left, that there was enrichment for higher scores in BRCA patients, as you would expect, but also among BRCA wild-type patients who responded. And this score difference between responders and non-responders was statistically significant both for BRCA patients and for all patients in the study. So we wanted to test this further, and that was specifically the LOH assay, the third component that I told you about. So we wanted to test this further in our metastatic trial, and this was a setting where, again, patients with triple-negative breast cancer were enrolled and underwent single-agent platinum treatment, cisplatin or carboplatin, 86 patients, and then subsets of those were available for molecular analysis. And what we saw overall was the same theme that I keep coming back to, that those who had germline BRCA mutations had a dramatically greater response rate than those who did not have germline mutations, and those unknown, of course, were in between. In this study, there was no difference, however, in progression-free survival between those who had or did not have germline mutations in BRCA, and I will come back to that. But of course, our question is about the BRCA-like assays. And here is the data looking at the BRCA assay and its correlation with the known BRCA status. So in this one, the y-axis is the HRD score. And you can see, as expected, that those with germline BRCA1 or 2 mutations, either germline or somatic, had higher scores in these assays, as well as in the mean. This is the LOH assay I told you about, the LST assay, and simply the numeric mean of those two. And in addition, that those who had BRCA promoter methylation, as you might expect if BRCA was silenced, also had higher scores as well in the individual and the composites. But of course, the real question is, if you take out the mutants, you look at the wild types, does this score have an ability to predict? And the answer appears to be yes. So these are all the BRCA germline mutations taken out. And you can see that both in the LST and LOH, there were a mean higher scores among those wild-type patients who were responding, that this was statistically significant for this relatively small cohort, that patients with very low scores, essentially never, there were no responses to platinum, and that interestingly and potentially unexpected, that in our study, those who had promoter methylation of the BRCA1 locus, even though they did have the higher scores in the HRD locus, in the HRD score, actually did not respond in our study. So then, if we go back and ask the same questions we did before, is this clearly better on a head-to-head comparison between the other triple-negative classifiers, the ones that I told you about? So this is looking at BRCA-like signature, and I went through a lot of this, so I won't go through it again, only to say that BRCA-like, although there was a trend for the BRCA-like in the same trial, as opposed to non-basal, having a higher response rate, this was not statistically significant. The same was true for the Vanderbilt signatures, not a predictive in this same study where the HRD scores seem to be a predictive. And secondly, if you look at these same functional mutations, P53, PIK3CA, slightly higher responses among P53 mutants, as you might predict, slightly lower responses in PIK3CA mutants, but again, not statistically associated with response. So some trend here toward increased predictive ability, but really we have a long way to go in these assays. And one of the, I think, most informative parts of this particular study in terms of how far we have to go in understanding these assays and improving the assays come from examining the progression-free survival curve. So remember, the assay was predictive of response even in non-mutants. Overall, the BRCA mutants shown here in the blue had a higher response, but then there's this interesting crossing of the curves. The yellow are the non-BRCA mutants, and it turns out that although BRCA mutants had a higher response, all of them rapidly progressed, again, single-agent platinum in metastatic triple-negative breast cancer, and that those with durable responses were all non-BRCA mutants. And when I say durable responses, we still have a number of patients in this study who had advanced aggressive triple-negative breast cancer who remained disease-free more than 6 years later. And there was no common hallmark of these patients, other than they all remain alive and disease-free. Many of them clearly were chemo-refractory. One patient had the tumor was obviously growing in the lung to anthracycline, taxane chemotherapy, started on platinum, complete response, alive 8 years later. But again, no correlation with p53, basal subset, PIK3CA. And if you look at the HRD scores, yes, they had higher scores than the mean. However, they were actually the lowest HRD scores among all the responding patients, even though they clearly had exceptional responses. And we're doing a lot of analysis of these patients. I can tell you they don't have somatic BRCA mutations. They do not have mutations in the other pathways that are known to convey risk for these cancers. And so we continue to work to figure out what this tells us about platinum response, what this tells us about DNA repair, and in particular, how it might help us improve our ability to develop and use these types of assays clinically going forward. So we have a long way to go, but more trials are ongoing. I'll just give you, to close, an example of one of those. This is a trial in the setting where we're randomizing to taxane-based chemotherapy or platinum-based chemotherapy and looking at the response as was done in TNT, but in this case incorporating the HRD analysis and asking whether HRD, the way that we've used it, really is a predictor of general chemosensitivity or a predictor specifically of platinum chemotherapy. If it's linked to the BRCA phenotype, it should be the latter, specific for platinum. I would also tell you that in the TNT trial, the randomized trial I told you about earlier, a different version of this same assays that I've been telling you about, which was a composite of all three, did actually not predict the response to platinum. It was different from the assay that was used in the two other studies, the preoperative study and our metastatic study that showed predictive capacity. It was different, and it remains to be determined. Investigation is undergoing as to why, in fact, there was a difference in that case. All of that to say, much more work needs to be done, but there are hints that we're getting somewhere. So finally, to close, the points I've made are that these tumors are specifically DNA repair defects, can be exploited therapeutically, and of course, just about everything that I said about platinum we believe will be translatable in the setting of PARP inhibitor in one way, and PARP inhibitor, of course, being a more specific and less toxic drug. Secondly, a subset of these BRCA intact tumors may exhibit this phenotype, not reflected in the traditional subtyping. The BRCA tumors may be identifiable through these patterns. We really need better assays. We don't understand exactly how they work, perhaps not just purely empirically derived, but perhaps specific hypothesis-derived assays. And then finally, that additional subsets may be distinct from the BRCA-like phenotype. Maybe those exceptional responders have a different phenotype that could be exploited and could be identified through a different assay. Identifying these subsets clearly may allow us to make better progress in personalizing and being more effective and less toxic with therapy. Thanks for your attention. I'd be happy to take questions.
In the TBCRC09 study, when you see the BRCA mutant patients who initially respond better to platinum and then they do worse, they pass away, do you check whether you have a... So platinum often induces a large number of indels in the tumor cells and in other cells as well. So do you see whether those BRCA mutations, if it's an indel-based germline mutation, they get back into frame and they become wild type like again? So would that explain most of the resistance or not?
Yeah, it's a good question. So one of the biggest questions in the field is if you take these BRCA tumors and they eventually progress, what allows them to progress? And there's a whole field of study. One of the ways is that by actually restoring the reading frame of the BRCA protein through a indel or other mechanisms. And in these cases, we did not see that. that has been observed in ovarian cancers as well as potentially some breast cancers, but we did not see that here, although we only had a limited number. These were, because I didn't say it, I should have, that the TBCRC, the metastatic platinum trial, we analyzed the primary tumors for response, and only in a limited subset did we have rebiopsy after resistance to look at that question, which is an important one.
Would you comment on BRCA-like tumors, BRCA-like phenotypes and other tumors like prostate?
Yeah, I think it's an excellent question. And I think that, if you were to say, well, what is the evidence that it exists? Probably the best evidence is that you do see responses with these PARP inhibitors in subsets of these tumors. And these are selective inhibitors. And so I think that that's probably the best evidence that there are subsets of other tumors that have a BRCA-like phenotype based on response to PARP inhibitors.
So ERCC1 is involved in platinum adduct repair. Is that an added potential confounding variable in these studies? What happens to ERCC1 in the BRCA mutant cases? Any information about that?
Yeah, it's a good question. We did genome-wide expression profiling, then validated for certain genes like ERCC1. And this, in the setting of triple-negative breast cancer in our study, ERCC1 was not a predictor.
So I thought it was an excellent presentation.
Thank you.
And actually, the way you presented it sort of minimized the importance. Okay, because at the end, you're comparing the triple-negative BRCA-like to the others who would have done worse had they not received platinum.
Yes.
I mean, so they do very well with platinum. If you had a comparison between platinum yes and platinum no,
exactly,
then you would have seen
it's
how
not that,
valuable.
Right, absolutely. It's not that platinum did not benefit. It's an excellent point you raise and often misunderstood. So it's certainly not the case that platinum did not benefit those patients. Because it wasn't a randomized trial and certainly not randomized to placebo. So there's every evidence to think that those patients may have benefited from the platinum.
Right,
absolutely.
yeah. And if you had done no platinum, you would have demonstrated that.
Absolutely.
And the other thing is, I thought the assay is quite good as you have it. I mean, sure, we want to develop better, but I thought this is remarkably good assay as it is right now. I'm not quite sure whether you think looking, which is I think what Dr. Bertino is alluding to, looking for specific mutations in all the genes that are involved in homologous recombination repair, whether that would be better. But I thought this was quite great in terms of enriching.
I think the challenge has been that the sobering moment came when the Stanford trial, the preoperative trial, looked at one of the three components. Our assay looked at two of the three components. Those both seem to statistically correlate. But then the TNT trial, where the three were put together as a composite in a little bit of a complex way by the company who developed it, it did not predict. So I think there we're a little bit having to relook at the data and what is the best version of the assay.
Leif, does it make a difference when you biopsy the tumor? And the reason I ask this question is because if you take the original biopsy specimen, you may not see mutations in BRCA1 or somatic mutations in BRCA1 and 2, but it seems as though with, for example, prostate cancer, that with treatment and relapse, that these patients become BRCA mutant.
Yes, somatic mutations in the metastatic setting. As I said, we only looked at a few where we had the matched primary metastatic, but we did not see that. But that's certainly one of the things to look for. Yeah, and we were, it was a big question overall whether, in fact, you could develop a predictor from the primary that predicts the response in the metastatic setting. The HRD seems to do so to some degree. Other of the markers, like the P6373, it seemed to be somewhat predictive in the preoperative setting, but not when you looked at the primary to predict the metastasis.
Jeff Wall.
Right.
So I'd like to be contrary, but I think it's important to start the discussion. It kind of looks like a duck and it walks like a duck, but is it a duck? So BRCA1, all kinds of implications, homologous recombination. But there have been a number of other papers that have been written that suggest that this gene or class of genes has different functions in the cell beyond that of homologous recombination. So is it possible that actually the lack of correlation that you just said is telling us something very important, that we actually need to be considering other kinds of assays, perhaps that are dependent upon the other functions imputed to BRCA genes and how that correlates with platinum sensitivity? And by the way, also perhaps explaining why it exhibits this exquisite organ site specificity, which would not be expected for a gene that's generally involved in homologous recombination.
Yeah, I couldn't agree more, and I think that there's no doubt that what we have seen to date is largely because it's been very difficult to develop assays to predict whatever function you want to ascribe to BRCA1 and 2, and that the assays that have been tested in these settings, as I said, number one, are purely empiric, and number two, based on the thing which was most readily measurable, which was simply genomic sizes and patterns of deletion. So I totally agree, and that's part of where we need to go.